Imagine surviving breast cancer. You do everything right. You go through the grueling treatments and you beat the disease.
Right. You're finally ready to just get your life back.
Exactly. Only to find out that the life-saving medication you're on is, well, it's fundamentally destroying your quality of life.
Yeah, it's a brutal reality.
And when you ask traditional medicine for a solution, the answer is often just a sympathetic shrug and sorry, we can't really help you.
Which is incredibly frustrating for these patients.
It is. So today, we are looking at a radical biological workaround for a reality that a lot of people face, but almost nobody talks about openly. We are diving into the world of intimate health and the biological realities of aging.
Because for many postmenopausal women, intimacy can become not just difficult, but incredibly painful.
Yeah.
I mean, due to severe physical changes.
Right. And for a specific subset of these women, those who absolutely cannot take hormone replacement therapy, the standard medical playbook just stalks cold.
Yeah.
So what do? What if the solution to regenerating that highly sensitive tissue isn't found in a pharmacy, but in a centrifuge?
That is the exact tension we're unpacking today. We're looking at a highly targeted biological workaround for a problem that is, frankly, far too often dismissed as just an inevitable part of aging, especially for women who have already been through the ringer medically.
Yeah, the mission for this deep dive is to explore a stack of clinical studies, medical reviews, and provider data to answer one highly specific question. Can the O-shot, which stands for platelet-rich plasma therapy, improve localized mucosal sensitivity in postmenopausal women with complete systemic hormone deficiency?
Yeah, we have clinical trial data from clinicaltrials.gov. We've got peer-reviewed studies published in journals like Maturitas and Menopause.
Right, and we're pairing all of that academic data with practical, on-the-ground insights from specialty urogynecology clinics, the ones that are performing this procedure every single day, which gives us both the theoretical science and the practical reality.
Okay, let's unpack this. To really understand how a treatment might fix a loss of sensitivity, we first have to understand exactly what is happening to this tissue in the first place.
Right.
So I want to get into the actual biological mechanism of this decline. Like, what is happening at the cellular level?
Well, the clinical term you see across all these sources is GSM, genitourinary syndrome of menopause.
Okay.
Historically, the medical community called it vaginal atrophy, but GSM is a much more accurate umbrella term. It describes the total systemic cascade of symptoms that happen when a woman's estrogen levels plummet.
Got it.
To understand the mechanism, you really have to realize that estrogen is not just a reproductive hormone. It's a structural one.
Oh, interesting.
Yeah. Think of estrogen as the master architect and the daily maintenance crew for the entire genitourinary tract.
Okay, I like that analogy.
It maintains the thickness of the vaginal lining. It keeps the mucosal tissues plump and hydrated. It ensures blood flow and, maintains elasticity. So when the estrogen disappears, that maintenance crew essentially just goes on strike.
They abandon the building entirely. Without that constant estrogen signaling, the tissues become dramatically thinner.
Wow.
They lose their moisture, the elasticity basically vanishes, and the tissue itself becomes highly fragile.
And the downstream effects of that are severe. Like, the sources note this leads to dyspareunia, which is the clinical term for painful sex.
Yes.
But looking at the literature, it goes way beyond just intimacy. It causes intense itching, daily burning, and even urinary incontinence because the tissues that physically support the urethra are, well, they're degrading right alongside everything else.
Exactly. It's a profound structural degradation. And here is where we hit the critical dilemma. For the general postmenopausal population, the gold standard treatment is often hormone replacement therapy, or HRT.
Right. Your systemic estrogen drops, your doctor replaces it. Problem solved.
Basically. Okay. But for a specific group of women, this is strictly off the table.
Right. We're talking specifically about breast cancer survivors, right?
Yep.
Particularly those taking aromatase inhibitors. Let's dig into why that is such a hard line in the sand.
Well, aromatase inhibitors are a class of drugs designed to actively hunt down and stop the body from producing even trace amounts of estrogen in peripheral tissues.
Oh, okay.
Because if you've had an estrogen receptor-positive breast cancer, any stray estrogen in your body could act like fertilizer for dormant cancer cells.
Oh, wow.
Yeah. So the medication enforces a complete, absolute systemic hormone deficiency to prevent the cancer from recurring. These women cannot take traditional HRT because introducing estrogen could quite literally risk a cancer recurrence.
Right. I want to make sure we're really visualizing the severity of the structural decline for you listening, because the common advice these women get is just to use, over-the-counter
All
lubricants.
right, the standard advice.
But based on the mechanisms you just described, using a standard lubricant on this tissue is like painting over a rusting pipe.
That's a good way to put it.
Like, it might look shiny on the outside for about an hour, and it might reduce friction temporarily, but it does absolutely nothing to stop the underlying structural decay.
Exactly. The pipe is still rusting.
The tissue is still degrading, so if we can't give these women systemic estrogen to fix the rust, aren't they just stuck?
This raises an important question. If the systemic hormonal environment, like the entire body, is fundamentally hostile to tissue health because of these cancer drugs, we have to look for a different biological pathway to trigger repair.
Right.
We have to figure out how to target tissue regeneration locally, entirely at the cellular level, without altering the body's systemic hormones.
And because traditional synthetic hormones are dangerous for this demographic, the medical field had to look inward, literally into the patient's own veins.
Yes.
I am fascinated by this next part. Let's walk through the mechanics of the O-shot, because the biology here is brilliant. It utilizes platelet-rich plasma, or PRP, and the process starts with a routine blood draw, just like going to the lab for a physical.
It does. They take a specific volume of your blood and they place it into a centrifuge.
Let's explain the physics of that for a second. A centrifuge is essentially a high-speed spinning machine, right?
Right.
Because the different components of your blood have different weights or densities, spinning them at incredible speeds forces them to separate.
Exactly.
So the heavy red blood cells get pushed all the way to the bottom of the tube. The lighter, watery plasma rises to the top, and right in the middle, you get this concentrated golden layer called the Buffy coat.
Yes. And this is the plasma that is absolutely packed with platelets. We really need to unpack why those platelets matter so much in this context.
Yeah, please.
Most people know platelets as the cells that stop bleeding when you get a paper cut. They rush to the site, clump together, and form a physical clot.
Right, the scabbing process.
But their secondary function is what we're actually utilizing for this therapy. Platelets are the body's first responders, sure, but they're also the project managers.
Oh, I see.
They carry microscopic cargo holds inside them filled with active growth factors.
I love that analogy. They're essentially extracting the general contractors from your bloodstream, concentrating them and dropping them directly onto a construction site.
That's exactly what's happening.
And the sources mention a few specific growth factors they carry, like vascular endothelial growth factor, or VEGF, and fibroblast growth factor, FGF. What exactly do those do?
Well, these proteins are signaling molecules, and they have very specific jobs. When they're concentrated and injected into a dormant area, they act like a biological megaphone.
Okay.
Vascular endothelial growth factor, as the name suggests, shouts at the local cells to start sprouting brand new blood vessels.
Wow.
And fibroblast growth factor tells the cells to start manufacturing new collagen scaffolding. They basically wake up the local dormant stem cells and force them to start building new infrastructure.
But there is a crucial clinical detail here regarding the sheer volume required to make this work, right?
Oh, absolutely. Concentration is everything. For PRP to actually cross the threshold from being, a neat biological trick to a viable tissue-altering therapeutic treatment, it must have a massive concentration of platelets.
How massive?
The clinical standard noted in the sources is a minimum of 1 million platelets per milliliter.
Which is exactly why the volume of the initial blood draw matters so much. This really stood out to me in the provider data. One of the sources explicitly points out that a standard 10 cc blood draw, which is sadly what a lot of lower-end clinics do to save money on kits, only produces about a 1.6 to 1.8 times concentration of platelets.
Right, which doesn't even come close to the therapeutic threshold.
No. To actually hit that 1 million platelets per milliliter mark, you need a much larger draw, like a 60 cc draw. That larger volume yields about a 6 times concentration.
It is the difference between an optimal clinical outcome and an expensive placebo effect. If you just inject a low concentration of platelets, the biological megaphone is too quiet.
They can't hear it.
Exactly. The dormant stem cells don't wake up. You need that massive 6 times concentration to physically force the biological cascade to begin.
Okay, so we've successfully isolated this highly concentrated liquid gold. The next step is the actual procedure.
Yeah.
The provider precisely injects this PRP directly into the chloral tissue and the anterior vaginal wall right near the G-spot. And this is where the triad of healing kicks in.
Yes. The concentrated growth factors trigger 3 simultaneous processes. First is angiogenesis, which is the formation of those brand new blood vessels we mentioned.
Right.
More blood vessels mean more oxygen and nutrients delivered to the starving tissue. Second is a massive ramp-up in collagen production, which restores the physical thickness, the structural integrity, and the elasticity of the mucosa.
Amazing.
And third is nerve repair, which is absolutely critical for restoring actual physical sensitivity.
Okay, but I have to stop you there and speak for literally anyone listening to this. Wait, a needle there.
I know.
That sounds like the absolute opposite of a good time. Like, that sounds terrifying, especially in an area that is already experiencing severe pain from atrophy.
It is a completely natural apprehension. Yeah. When the idea of a needle in highly sensitive, degraded tissue sounds barbaric.
Truly.
But the clinical reality bridges the gap between a scary-sounding concept and a practical, routine procedure. The secret is the numbing protocol.
Okay.
Before any needles come anywhere near the patient, the provider applies a highly potent, medical-grade, topical lidocaine cream.
How does that actually work to stop the pain, though?
Well, lidocaine works by temporarily blocking the sodium channels in the nerve endings. If the sodium can't get into the nerve cell, the nerve literally cannot send a pain signal to the brain.
Oh, wow.
Yeah, the provider lets this cream sit until the entire area is completely anesthetized. The sources from the clinics consistently report that because of this protocol, most women feel only a slight pressure or a sensation of warmth during the injection, not sharp pain.
That is such a relief.
It transforms what sounds like a terrifying ordeal into a quick in-office procedure that takes just minutes, with virtually zero downtime.
That makes total sense. They've engineered a way to bypass the discomfort of the delivery mechanism.
Yes.
And we now know how it theoretically works to bypass systemic hormone therapy by using your own concentrated growth factors to trigger angiogenesis and collagen production locally.
Exactly.
But theory is one thing. The most important question we have to ask of our sources is, does the clinical data actually prove it improves mucosal sensitivity for these women? Like, we need to look at the numbers.
And the clinical data on breast cancer survivors is particularly compelling, precisely because they are the hardest population to treat.
Right.
One of the clinical trials we reviewed, a phase 2 pilot study published in 2018, specifically focused on post-menopausal women with a history of breast cancer. They found that applying PRP significantly improved the physical structure of the tissue and reduced the symptoms of GSM.
And there's another pilot study from the clinical stack that really caught my eye. They took 68 women in their early 60s. The results they published were honestly staggering. They reported that 94% of the women expressed satisfaction with the treatment for issues like painful sex and lack of lubrication.
94%.
Here's where it gets really interesting. I'm going to push back on that, though. Wait, 94%?
Yeah.
In medical science, a 94% satisfaction rate sounds almost too good to be true, especially for a condition this notoriously stubborn. What is the catch here?
That is fantastic pushback, and you are absolutely right to be skeptical of a 94% success rate in a single pilot study.
Right.
Pilot studies are often smaller and they can skew high. When you look at the broader clinical landscape and aggregate the provider data, this isn't a magic wand that works perfectly for every single person. The broader clinical studies show a real-world success rate hovering between 60 and 85%.
Okay, which means 15 to 40% of women might go through this entire blood draw and injection procedure and not see significant life-changing results.
That is the reality of biology. It depends heavily on the baseline health of the tissue before the injection, the severity of the atrophy, and individual cellular responses.
That makes sense.
Providers emphasize this 60 to 85% transparency because it is vital for informed consent. If the tissue degradation is too advanced, or if there are other underlying pelvic floor muscle dysfunctions contributing to the pain,
Right.
PRP alone might not be the silver bullet.
Right.
Managing expectations is a critical part of the clinical process, especially when dealing with patients who might be feeling, desperate for relief.
That context is super helpful, but for the 60 to 85% of women who do respond well, the timeline of these results is fascinating.
It is.
It's not like taking an aspirin where you feel better in 20 minutes. Because we're talking about actual cellular regeneration, it takes time.
Right.
The clinic data shows that initial improvements in sensitivity usually begin to show up in about 1 to 3 months. But the full cellular regeneration, the mature new blood vessels, the dense new collagen matrix, that really peaks at the 2 to 3 month mark.
Yeah, it takes time for the general contractors to build the new infrastructure.
Mm-hmm.
And the effects aren't permanent because the biological clock keeps ticking and aging continues, but they are long-lasting.
Wow.
The data suggests the structural benefits hold for about 12 to 18 months, at which point many women opt for a quick maintenance session.
What I love about these sources is that they aren't just relying on subjective surveys where patients say, I feel better. There is objective, microscopic laboratory proof that the tissue is physically transforming. They use a diagnostic tool called the Vaginal Maturation Index, or VMI.
The
Wow.
VNMI is brilliant in its simplicity.
Let's explain how it works. It's a lab test
Okay.
where they take a gentle swab of the vaginal lining, put those cells on a slide, and look at them under a microscope.
Right.
They're specifically looking at the ratio of immature cells versus fully mature cells.
Exactly. Under a microscope, an immature cell called a parabazole cell looks small, round, and fragile. It doesn't have the robust structure needed to withstand friction. A fully mature, superficial cell is large, flat, and plump with glycogen, which provides natural moisture and durability. In a woman suffering from complete hormone deficiency, that index is heavily skewed toward those tiny, fragile, mature cells.
But after the PRP treatment, when they swab the tissue again months later, the VMI shows a massive shift back toward mature, robust, superficial cells.
Yep.
The tissue is physically maturing and thickening. And the incredible part is, this is happening entirely without the presence of systemic estrogen. The local growth factors from the platelets are doing all the heavy lifting.
It's incredible to see on a slide.
So we've established that PRP is a powerful tool, but if I'm a listener and I happen to fall into that 15 to 40% who don't respond to the O shot, I'm going to be looking for a plan B.
Naturally.
Since we can't use systemic estrogen, what else is on the table? How does PRP compare to the other non-hormonal treatments out there?
Well, if we look at the pharmaceutical route, one of the primary alternatives is a drug called ospemifene. It belongs to a class of medications called SERM-selective estrogen receptor modulators.
The mechanics of SERMs are really interesting. It's non-hormonal, but it mimics estrogen in very specific tissues using a lock-and-key mechanism.
Right.
It's designed to selectively bind to the estrogen receptors in the vaginal mucosa and tell those specific cells to thicken up and produce moisture while theoretically ignoring the estrogen receptors in the breast tissue.
It does improve the vaginal mucosa, but the sources point out a significant caveat regarding that selective binding.
Uh-oh.
The locking mechanism isn't always perfect. Studies have shown a statistical increase in endometrial thickness, meaning the lining of the uterus, in women taking ospemifene. This thickening was detected at both 12 weeks and 52 weeks of use.
The clinical sources called that finding thought-provoking, which,
Yeah.
let's be honest, is medical speak for. We need to watch this very, very closely.
Absolutely.
If you're a breast cancer survivor, specifically taking aromatase inhibitors to avoid any estrogenic effects in your body because it could feed a cancer, taking a drug that inadvertently thickens your uterine lining is a major safety concern.
It is a systemic risk that many in this demographic and their oncologists are simply unwilling to take, which leaves us with energy-based devices. Specifically, vaginal laser therapy using CO2 or EYAG lasers.
I'm struggling to understand the laser aspect. When I think of lasers, I think of cutting metal or burning things. How does burning this highly fragile, already damaged tissue actually help heal it?
It is entirely counterintuitive, but it's a concept borrowed straight from cosmetic dermatology. These lasers are fractionated, meaning the light beam is broken up into tiny microbeams.
Okay.
They create highly controlled microscopic wounds, essentially tiny thermal burns deep in the vaginal tissue while leaving the surrounding tissue intact.
Ouch.
Well, the body senses this microdamage and immediately rushes its own healing factors to the area, stimulating rapid collagen production to repair the burns.
And the sources show they do offer short-term benefits. Breast cancer survivors who underwent this fractional laser therapy reported measurable, significant drops in pain levels during intimacy and a reduction in daily dryness.
They absolutely offer relief. However, the American Urogynecologic Society points out a critical limitation in our current knowledge. There are no published randomized placebo-controlled trials specifically for this cancer survivor population.
Oh, wow.
And more importantly, the long-term biopsy data is still very limited. We simply don't have a complete long-term microscopic picture of how repeated thermal laser ablation affects this specific estrogen-starved tissue over the course of 5 or 10 years. Does it eventually cause scarring? We don't fully know.
There's actually a fascinating clinical trial underway right now, mentioned in our sources, trying to solve that exact blind spot. They're using OCT imaging to track the long-term changes.
Optical coherence tomography.
Right. And to explain how that works, think of an ultrasound, which uses sound waves bouncing off your organs to create a picture. OCT does the exact same thing, but it uses light waves instead of sound waves.
Like,
It takes these incredibly detailed, non-invasive cross-section pictures of the tissue. They're using this tech to measure the exact thickness of the mucosa and the density of the blood vessels before and after laser therapy, just to try and get better, objective, long-term safety data without having to constantly biopsy the tissue.
and if we connect this to the bigger picture, when you look at the whole board, when you compare the imperfect selectivity of SERMs and the thermal microwounds of lasers to the PRP approach, you start to see why the O-shot has gained so much traction in urogynecology.
It really all comes down to what the sources call the autologous advantage.
Autologous simply means it is derived entirely from the patient's own body. With the O-shot, you aren't introducing a synthetic chemical like aspermethine that might inadvertently pick the wrong cellular lock and trigger receptors in the uterus.
Right.
You're not creating thermal microwounds with a laser and hoping the tissue doesn't eventually scar. You are extracting the patient's own biological healing concentrate, their own general contractors, and putting them exactly where they are needed.
It's so targeted.
There is no risk of an immunological reaction, no allergic response, and absolutely no systemic hormonal side effects. For a woman with a medically enforced complete systemic hormone deficiency, it is a uniquely safe avenue.
So what does this all mean? When we look back at the core mission of this deep dive, can the OSHART actually improve localized mucosal sensitivity in post-menopausal women with complete systemic hormone deficiency who cannot take HRT?
The answer from our stack of clinical sources is a resounding yes.
Yeah, it offers a highly promising, scientifically backed method to combat GSM. It ingeniously bypasses the body's lack of systemic estrogen by leveraging your own localized cellular repair mechanisms.
Right.
It uses your own platelets and your own growth factors to rebuild the blood vessels, repair the nerve endings, and lay down a fresh collagen matrix from the ground up.
It represents a fundamental paradigm shift in how we approach tissue degradation. We are no longer entirely reliant on replacing the missing hormone. We're triggering the repair mechanisms directly at the site of the damage. And that leaves us with a truly fascinating bigger picture question to consider.
What's that?
If we can successfully use concentrated growth factors extracted from our own blood to regenerate dense nerve networks and highly sensitive mucosal tissues in the reproductive system, and do it completely without synthetic hormones, what is the limit of this technology?
Oh, wow.
Could this autologous PRP approach eventually be adapted to repair other complex mucosal or neurological degradations in the body? Could we be looking at a future where we entirely replace the need for synthetic pharmaceuticals in managing age-related tissue decline, relying instead on the hidden healing architecture currently circulating in our own veins?
That is an incredible thought to walk away with. The power to heal, literally circulating inside you right now, just waiting to be concentrated and deployed. Thank you for joining us on this deep dive. Keep asking questions, keep challenging the standard medical playbook, and keep exploring the fascinating science of your own bodies. Until next time.